There's a large multi-arm, multi-stage trial that's been recruiting since 2005 across now more than 100 centres in the UK, plus centres in Switzerland. The original version of the trial was looking at 3 drugs, docetaxel, zoledronic acid and celecoxib. We dropped the celecoxib-containing arms in 2011 after pre-planned interim analyses showed insufficient activity. Zoledronic acid, docetaxel and the combination of the two got through all of the interim analyses and completed recruitment in 2013, and then we're presenting the results from the database lock at March 2015, so 2 years minimum follow-up on the last patient entered. What we're going to present is that for zoledronic acid, firstly, there's a weak effect on failure-free survival, a weak effect on overall survival. Doesn't amount to statistical significance, and it doesn't hit any sort of clinically significant magnitude. So our conclusion from the zoledronic acid data is that zoledronic acid should not be part of upfront care for newly diagnosed men with prostate cancer. So the men going into the trial essentially can be described as men starting long-term hormone therapy for the first time, which is the mainstay of treatment for advanced disease. We defined it formally in terms of either newly diagnosed metastatic, node positive at diagnosis, or patients with high-risk features without spread, so high PSA, high Gleason, high T stage. Around 60% of the patients going into the trial are metastatic, 40% are high-risk non-metastatic, of whom mostly they're high-risk node-negative patients. For the non-metastatic patients, they had the option of also receiving radiotherapy, and overall about 70% of them have had radiotherapy to the prostate plus or minus to the pelvic nodes. The most interesting part of the data we're presenting tomorrow is the docetaxel data. Basically what we show is that for both the metastatic and the non-metastatic subgroups, addition of 6 cycles of docetaxel at the time of diagnosis prolongs failure-free survival by about 40%. So it's a big effect, and it's consistent across the whole trial. It's not just for the metastatics or whatever, it's a very consistent effect. For the whole trial, the addition of docetaxel up front, both M0s and M1s, improves survival with a hazard ratio of about 0.75, so it's about a 25% improvement in overall survival from adding up front docetaxel. We have a pre-planned analysis for the metastatic group only. The magnitude of benefit in that group is a little bit larger. That translates into a 22-month improvement in median survival, basically improved survival from about 3 years to about 5 years for men starting hormone therapy for metastatic disease for the first time. For the M0 cohort, we also have a pre-planned analysis for that, but actually we have so few deaths, we have fewer than 100 deaths on the control arm for the M0s, that we're completely underpowered to say anything very much about survival in the M0 subgroup. We would say, however, that the magnitude of the effect on failure-free survival is consistent across the whole trial. There's no reason to think that there won't be an effect on survival for the M0 patients. We just need more follow-up to have sufficient deaths to see it. The other thing we've looked at in the trial, because there's been 2 prior trials in the metastatic setting that have looked at upfront docetaxel. There's a French trial, GETU 15, which also showed improvement in failure-free survival, but no survival improvement. And the Charted trial, which is a US trial, which presented at ASCO last year, which showed an improvement in both failure-free and overall survival, particularly, they said, focused on the high-risk subgroup. Now, we can't subdivide our trial up into high risk and low risk the same way as the Charted trial did, because we didn't collect the same data at baseline, but our effect looks consistent across the whole metastatic population. We split it up by performance status or PSA or whatever, the benefit looks the same, so we don't think there's any need to subdivide the metastatics up. If you amalgamate the data from the Charted and the GETU trial, you get an estimate of the hazard ratio for benefit about the same as the one we've observed, so we think probably the 25% improvement is about the right estimate for what happens if you give chemo up front. Our conclusion from the UK group is that docetaxel should be pretty much standard of care for fit patients starting hormone therapy for the first time with metastatic disease. For the non-metastatic patients, there is a big improvement in failure-free survival, which clinicians may or may not think justifies giving upfront docetaxel. Clearly that's a more difficult question. We've got a meta-analysis planned with the other docetaxel and the other zoledronic acid trials, which we're hoping to present the first results of at the ESMO meeting this autumn. That will help to clarify the position in the M0 patients.